Hello everyone, so we're going to talk about hemolytic anemia here. So what is hemolytic anemia? It's simply anemia due to the destruction of red blood cells. Anemia being a lower than normal hemoglobin and destruction of red blood cells being the destruction of red blood cells. So unlike the microcytic anemias where you can have it from a low iron, or you can have it from a congenital condition like thalassemia, or the macrocytic anemias where it's generally due to a vitamin B12 or a folate deficiency. This is anemia that's actually due to destroying the red blood cells. And this can happen in the spleen, or it can happen in, the spleen or the liver, or it can happen in the vasculature itself, or it can be going on in both. So if it happens in the spleen or the liver, that's considered extravascular, and if it happens in the vasculature itself, that's considered intravascular. And with intravascular, one of the things that we see specific to that is we see hemoglobin in the urine, because you're getting hemoglobin out of the red blood cells and it filters through the kidneys. And we see that particularly in PNH, which we'll talk about. So this is a normocytic anemia, and that's unless there's any other anemia that's coexistent. Of course, you can have hemolytic anemia and have iron deficiency, or you can have hemolytic anemia and be B12 deficient or folate deficient. That's possible. But hemolytic anemia itself is a normocytic anemia because you're just destroying your red blood cells. The ones that aren't being destroyed, they're healthy. They're normal. In addition to the anemic symptoms, which of course are fatigue, weakness, pallor, shortness of breath, and so forth, there are going to be unique factors of hemolytic anemia that's due to the destruction of the red blood cells and the metabolism of hemoglobin. So one of the things that you can see is splenomegaly, and that's because the spleen is one area where the blood cells can get broken down. And so the spleen can get enlarged if there's more red blood cells being broken down in the spleen. You can get jaundice, icterus, and pruritus, and this is all related to an elevated bilirubin. Why do we get an elevated bilirubin? Because bilirubin is a metabolism product of hemoglobin when it's been metabolized. So you get the jaundice, which is bilirubin in the skin, makes it yellow, icterus in the eye, yellow eyes. Pruritus is itchiness. So you get this sort of generalized itchiness, and that can actually precede the jaundice. And that's just because, well, you're not supposed to have bilirubin in your skin. So when you get bilirubin in your skin, your immune cells will respond to that and release histamine and cause itching. Gallstones are a possibility with hemolytic anemia, although it's very rare for that to be a presenting complaint for hemolytic anemia, but it is possible with patients who have chronic hemolytic anemia. Again, that's because of the elevated bilirubin. Hemoglobinuria is the technical term for having the breakdown of hemoglobin in the blood. So when hemoglobin gets broken down, it gets filtered into the blood, or gets filtered into the urine rather, and then goes out in the urine, and that will be detected on urinalysis. And then constitutional symptoms, and that's going to be primarily in the acquired hemolytic anemias. That's, of course, just fever and weakness and chills and so forth. Okay, so let's talk about the different hemolytic anemias. So we can classify these based on Coombs positive and Coombs negative. What the Coombs test is it's just testing for the existence of complement and immune products. So Coombs positive hemolytic anemias tend to be acquired, and that can be acquired due to a disease, due to a drug, due to an infection. And these tend to be more sudden, so these tend to be the things that give you more of the constitutional symptoms. So they can present, in addition to the anemia and the jaundice, they can present with a fever and chills. Not always, but they can. With the hereditary hemolytic anemias, or the Coombs negative, I use the slash there because not all of these are hereditary. The Coombs negative are due to something else that has nothing to do with the immune system. So hereditary spherocytosis and paroxysmal nocturnal hemoglobinuria are both due to membrane defects. Glucose 6-phosphate dehydrogenase deficiency is due to an enzymatic problem, and then sickle cell disease is due to a point mutation on the beta globin. So these are all due to the red blood cell itself. It has nothing to do with the immune system. And so these are Coombs negative. When you think Coombs, just think immune. There are two other causes of hemolytic anemia that are important for the USMLE. Microangiopathic hemolytic anemia, which will be discussed separately, along with platelet diseases, and mechanical hemolytic anemia, which I'm not going to discuss at length because it's really clinically irrelevant. That's a hemolytic anemia that can be due to trauma to the body, like running on hard surfaces. It can also be due to a prosthetic valve. That's just due to something actually physically destroying the red blood cell, not a disease process itself. Sickle cell disease will be discussed in its own separate section because it's a more of a complex disease that has its own management and therapy and so forth. Okay, so when do we suspect hemolytic anemia? So patients can present with just general anemic symptoms and no other features. That's common. So they might not have cholecystitis or jaundice or icterus and pruritus. Of course, if those things happen with anemic symptoms, then you are definitely pointing in on hemolytic anemia. But that doesn't always happen. So sometimes you can just get patients that are anemic and have no other features. They're just short of breath, they're tired, they're fatigued, they're weak, they're pale. That can happen. And so in any investigation for anemia, as well as getting iron workups and B12 and folate, you should also be getting serum LDH and haptoglobin. And those are going to be pointing you towards hemolytic anemia if they're off, if they're abnormal. So with the serum LDH in hemolytic anemia, that will be high, and haptoglobin will be low. I'm not sure if haptoglobin does this, but when I was going through the tests, the way I always remembered it was haptoglobin eats hemoglobin. So hemoglobin eats haptoglobin. So if there's excess hemoglobin around when it gets broken down, it's going to eat up the haptoglobin. So with hemolytic anemia, it's eating up the haptoglobin. Take it or leave it. And then, of course, the total bilirubin is going to be high. So that's simply because hemoglobin is getting broken down into bilirubin. And specifically, the indirect bilirubin will be high. Okay, so in hemolytic anemias, as mentioned, your LDH is going to be high, haptoglobin will be low, and reticulocytes are going to be elevated. Now, this is what differentiates this normocytic anemia. Remember, hemolytic anemia is normocytic. It's going to have a MCV of between 80 and 100. This is what's going to help you differentiate hemolytic anemia from perhaps anemia of chronic disease. With anemia of chronic disease, your reticulocytes are going to be suppressed because you have chronic inflammation. With hemolytic anemia, you're going to have elevated reticulocytes because your bone marrow is healthy, so it's going to be pumping out more reticulocytes, more future red blood cells. Patients who have a normocytic anemia, particularly those who are otherwise healthy, those are the ones that you're strongly considering for hemolytic anemia. Even if they don't have jaundice symptoms or cholecystitis or so forth, patients with normocytic anemia who are healthy, you should be thinking hemolytic anemia. The other cause of normocytic anemia in otherwise healthy patients would be blood loss, but usually people know if they're losing if they have acute blood loss, not chronic blood loss. So normocytic anemia in healthy patients, you should think hemolytic anemia. But that LDH and haptoglobin and the bilirubin labs are going to be what really point you towards this is definitely hemolytic anemia. Now I need to find out what kind of hemolytic anemia it is. In general, as far as the treatment, and I want to stress this, all patients who are diagnosed with hemolytic anemia should be getting folate supplementation in one way or another, be it oral or parenteral, and generally it's oral supplementation. And so if I don't mention that for each individual disease, I'm mentioning it now. With any hemolytic anemia, you should be getting folate supplementation at the very least. Okay, so let's talk about the Coombs positive or acquired hemolytic anemias. So autoimmune hemolytic anemia or warm hemolytic anemia. This is a Coombs positive hemolytic anemia, and it's usually idiopathic, so usually we don't know what's causing it. But when we do, it's often linked to a lymphoproliferative, so like leukemia or lymphoma, or to an autoimmune disease. So lupus, scleroderma, rheumatoid arthritis, and so forth. So some people like to use the term warm hemolytic anemia just to differentiate it from the cold-agglutinin hemolytic anemia, but this autoimmune hemolytic anemia can be used because it's linked with autoimmune disease, and so different people use different terms. But know that the ones that are caused by lymphoproliferative or autoimmune diseases, or the ones that are idiopathic, are the warm hemolytic anemia. The cold-agglutinin disease is its own entity. So this, as I mentioned, is Coombs positive, and it's linked to something like leukemia or lymphoma or an autoimmune disease. The best initial test for to get us on the way to diagnose autoimmune hemolytic anemia is, of course, to get a Coombs test. Coombs test is otherwise known as the direct antiglobulin test, direct Coombs test, and this will be positive in all of the hemolytic anemias that are acquired. So autoimmune, drug-induced, and cold-agglutinin hemolytic anemia. Those will all have positive Coombs test. However, with the cold-agglutinin hemolytic anemia, as you're going to see when we talk about it, those will have certain symptoms that are specific to it. So it'll be worsened at lower body temperatures, and they can be linked to certain infections. So autoimmune hemolytic anemia, warm hemolytic anemia, will be a positive Coombs test, and more often than not, and I would say on the USMLE, you will have it be linked, the patient will have a lymphoproliferative or an autoimmune disease. However, it can be idiopathic. If they don't have an autoimmune disease or a lymphoproliferative disease, then you should probably get a cold-agglutinin test, and that will help you differentiate it from the cold-agglutinin hemolytic anemia. So the treatment here is going to be folate supplementation, and if it's particularly bad, you can use corticosteroids like prednisone, but generally patients who have autoimmune diseases are already going to be on steroids. Okay, cold-agglutinin hemolytic anemia. So this is the one that you kind of want to differentiate the warm autoimmune hemolytic anemia from. So this is also Coombs positive. A lot of times this can be linked to an infection. So it can be like mycoplasma. It can also be mononucleosis. That's the Epstein-Barr virus. It can also be linked to HIV. And sometimes it is associated with leukemias and lymphomas. The key differentiator, though, from the warm hemolytic anemia that we just talked about is that the cold-agglutinin hemolytic anemia that we're talking about here is worsened with exposure to cold, and a lot of times that's going to be present on the patient's history. Furthermore, where are the cold parts of your body? If you even feel your body, you'll know that the coldest part of your body are your fingers and your toes, because it's most distal from your heart. So patients with cold-agglutinin hemolytic anemia oftentimes come in with this accompanying purplish discoloration of their fingers and toes, a lot of times after they get in from cold weather. So the best initial test, again, because we are suspecting an acquired Coombs positive hemolytic anemia, because all we know initially is that this is a hemolytic anemia, the best first test is to get a Coombs test, because you need to know, okay, this is a Coombs positive hemolytic anemia, because that's going to set the management very different from the Coombs negative hereditary hemolytic anemias, which we'll talk about later. So a Coombs test is the first thing you get once you've diagnosed hemolytic anemia. This, of course, will be positive because this is an acquired hemolytic anemia, and you can get a cold-agglutinin titer, and that will also be positive, and that will definitively distinguish it from the warm autoimmune hemolytic anemia. I would say on the USMLE, they classically liked to say that you have a 27-year-old patient presenting blah, 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 hemolytic anemia, blah, 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 and 2 weeks ago they had blah, 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 symptoms of walking pneumonia, fatigue, shortness of breath, unproductive cough, and so forth. They like to link it with mycoplasma. So remember, cold-agglutinin hemolytic anemia with mycoplasma, but it can be linked with various different diseases. The treatment here is going to be folate supplementation and, of course, avoiding the conditions that cause it. This will eventually go away, but you do need to avoid cold conditions to prevent the hemolytic anemia, and that will generally be enough. Rituximab, which is an anti-CD20 monoclonal antibody drug, has been used to some success, but that's only for really bad refractory cases, and it's certainly not necessary. For the USMLE, no, folate supplementation and avoiding cold conditions, wearing gloves, and so forth for cold-agglutinin hemolytic anemia. And the cold-agglutinin titer will distinguish it from warm autoimmune hemolytic anemia if you've got the symptoms that are pointing you towards cold-agglutinin. Okay, drug-induced hemolytic anemia is rare, but it's pretty obvious when you get it on the USMLE because it's hard for them not to describe it, obviously. So again, you have a Coombs-positive hemolytic anemia, but you also have a drug that's highly associated with hemolytic anemia. Now, that doesn't mean that those drugs cause hemolytic anemia often, but it means that when you have drug-induced hemolytic anemia, it's traced back to these specific drugs almost always. So the most common drugs that are associated with hemolytic anemia are the cephalosporins. So if you have a patient with hemolytic anemia, Coombs-positive hemolytic anemia, that's on a cephalosporin, you should be stopping the cephalosporin. Other drugs that can be causing drug-induced hemolytic anemia are levofloxacin, so another antibiotic, nitrofurantoin, which is another antibiotic commonly prescribed for bladder infections, rifampin, which is an anti-TB, carbidopa and levodopa, which is used for Parkinson's disease, alpha-methyl-dopa, which is used for lowering blood pressure during pregnancy, particularly, and various other diseases. Those are the ones, though, that will be most commonly given on the USMLE. I can't imagine them giving you something else because these drugs together make up probably 95% of the drug-induced hemolytic anemia cases, and it is rather rare. So cephalosporins, remember that one if you don't remember any other one. So drug-induced hemolytic anemia. Again, positive Coombs test because this is something, a drug or an autoimmune condition or an infection that's causing an antibody response that's resulting in red blood cell destruction. It's an antibody response. So you're going to get a positive Coombs test, like all the other ones. And recent usage of an associated drug, so one of these, should give you your presumptive diagnosis, and that drug should be discontinued or replaced. And the treatment, of course, stop the offending agent. Supplement with folate. Because you've had all this hemolysis, you've lost folate, so you should supplement the patient with folate until the hemolytic symptoms are gone and really until they are no longer anemic. Okay, so how about the hereditary or Coombs negative hemolytic anemias? So there is one of these one of these are non-hereditary, but they're all Coombs negative. So I'm grouping these all together, but two of these are hereditary, they're all Coombs negative. So just as a note, patients with hereditary spherocytosis and PNH, which is paroxysmal nocturnal hemoglobinuria, which is actually the non-hereditary one, and G6PD deficiency, these ones that we're going to talk about, all of these patients with the Coombs negative anemias are at risk for aplastic crisis, and that's correlated with parvovirus B19, infamously. So it's very important to educate the patient about this because aplastic crisis can be deadly. And that would be aplastic of all the cell lines, so pancytopenia. We'll talk about that in a separate section. But know that patients with these hemolytic anemias are at risk for that. Okay, hereditary spherocytosis. So this is a hereditary condition, as noted in the name, and it follows an autosomal dominant pattern. However, Some lines have followed an autosomal recessive pattern, but most often it's an autosomal dominant disease. So you will have a family history that's easy to trace, because you can't get an autosomal dominant disease without one of your parents having it. Red blood cells in hereditary spherocytosis lack a membrane protein, and that membrane protein, which is known as spectrin, is responsible for helping the red blood cell maintain its nice donut-like shape. And that donut-like shape is important for its flexibility to get through capillaries, and particularly to get through the red pulp of the spleen. And remember what the spleen does. The spleen gets rid of old, unflexible red blood cells. Red blood cells lose their flexibility as they get older, and that's a good thing that we get rid of those ones. However, when you have hereditary spherocytosis, you're going to have a lot of red blood cells that are going to be unflexible from the get-go, and so you'll have a lot of red blood cells being destroyed in the spleen, and that's not good, because that's going to cause anemia, hemolytic anemia. So how do you diagnose this? Well, particularly, you're going to have, when you have a family history, and a lot of times you diagnose this in children, but when you have a family history of hereditary spherocytosis or a family history of hemolytic anemia, then the best initial test would be an osmotic fragility test. Now let me back up a little bit. A lot of times, before you even get to that point of ordering an osmotic fragility test or a Coombs test, you will have already gotten your CBC with a smear, and your smear will show spherocytes. So your tech in the lab will already be telling you that there are positive spherocytes. So you'll already know this is probably spherocytosis. But the osmotic fragility test is the best test to diagnose hereditary spherocytosis. If you have a Coombs test, it will be negative, because this is a disorder of the red blood cell. It has nothing to do with immune complementation or antibodies or anything like that. So the treatment here is going to be folate replacement. There's really nothing else we can do for this, because this is a genetic condition. You can remove the spleen, and removing the spleen will cure the hyperbilirubinemia and the hemolysis, but it's not going to actually get rid of the spherocytes in the blood. So you'll still have spherocytes in the blood, but the splenectomy can be useful because you can reduce the breakdown of those spherocytes, and when you don't have the breakdown of the spherocytes, then you're not going to have the hyperbilirubinemia. Now, the problem with that is that when you remove the spleen, you also get rid of the spleen's immune properties. So you're going to have to make sure that you vaccinate, get the pneumococcal vaccine at the very least. Another thing that can point you towards hereditary spherocytosis is that you're going to have a decreased mean corpuscular hemoglobin concentration, MCHC, I believe is what it is. So that's shown to you on the USMLE. The concentration, an increased hemoglobin concentration, and that's because the red blood cells are smaller, but they still have the same amount of hemoglobin. So if you get an increased hemoglobin concentration in the red blood cells, that is indicative of hereditary spherocytosis. So here is hereditary spherocytosis on the smear, and these are the spherocytes. Here's 1, here's 2, here's 3, here's 4, and you get some normal red blood cells. So sometimes on a MCV, you may have a slightly microcytic anemia. So you might not have a normocytic anemia in this case, but if it is microcytic, it'll just be slightly. And your iron studies will be completely normal. So this is the one possible exception of hemolytic anemia that might not be totally normocytic. But if it isn't normocytic, it's going to be just at the very, very, very high end of microcytic. Okay, here's another one. Okay, paroxysmal nocturnal hemoglobinuria, PNH. That is a mouthful, so I'm just going to say PNH. This is an idiopathic condition, so this is not hereditary, and it's actually a clonal defect in the RBC membrane protein. So Similar to hereditary spherocytosis, you've got a defect in the membrane, but this is not part of the structural membrane. This is part of the membrane that keeps complement away from the red blood cell. So the protein is GPI, and GPI is responsible for keeping complement away from the red blood cell. So if you lack or you have an error GPI protein, then what's going to happen is you're going to have more complementation of the red blood cell and more hemolysis. The cells are going to be destroyed intravascularly because you're getting more complementation. Now, you don't have abnormal antibodies here. So I want to stress that. You're still going to get a Coombs negative test because there's nothing changed with your immune system. It's not like the autoimmune hemolytic anemia or the drug-induced hemolytic anemia where you're getting antibodies targeting your red blood cells. Here, you're just having the normal process of complementation going on. It's just happening more frequently. It's happening faster because you lack this red blood cell membrane protein. So Coombs test is still going to be negative. Because your cells are destroyed intravascularly, that's going to cause the blood in the urine, the hemoglobin in the urine. So why does this happen at night? Well, we do get a little bit more, normally, we do get a little bit more complementation of the red blood cells, destruction of the red blood cells at night because we have a slightly acidotic state, or more acidotic than normal, when we're sleeping because we're not breathing as deeply when we're sleeping. So at night, these patients with PNH will have these spells where when they wake up, they have this dark or cola or tea-colored urine, which is present with their first urine of the day, but as the day goes on, it clears up. So the hemolysis primarily happens at night, and that's because the lower oxygen states is going to promote the increased complementation. Now, patients who have paroxysmal nocturnal hemoglobinuria, it's important to remember this for the USMLE, have an increased risk of thrombosis, venous thrombosis in general, and this has to be addressed at least through patient education or through monitoring. Okay, so some of the thromboses that are specifically prevalent in PNH are going to be a hepatic thrombosis, which can be manifested as ascites, the Budd-Chiari syndrome. You can get dermal thromboses, so those would present as painful nodules on the skin. So keep in mind that PNH is associated with thrombosis. Okay, how do we diagnose PNH? We diagnose it classically with the acidified serum lysis, or HAMS test. HAM is the name of the guy who came up with the test, so it doesn't stand for anything. It doesn't mean pig or anything like that. So acidified serum lysis, HAM test. Other tests exist. There's flow cytometry. There's something called the sugar water test, but most frequently on the USMLE, when they're asking you for the test to diagnose PNH, it's going to be the acidified serum lysis or HAM test. And like I said, there are other tests that exist. Urinalysis will show hemoglobinuria, or more specifically, hemosideриnuria. The treatment for paroxysmal nocturnal hemoglobinuria is going to be iron and folate supplementation. Why iron supplementation? This is an intravascular loss of hemoglobin. So we're losing hemoglobin, we've got to replace the iron that's lost with that hemoglobin. It's not being lost in the spleen where we can pull that iron back into the blood. So we've got to replace the iron too because you're peeing out your blood. So iron and folate supplementation. If you have severe cases, you can use steroids. However, I don't imagine that coming up on the USMLE, but in clinical practice, you may use steroids if it's severe enough. Anticoagulation is elective. There isn't really any evidence to show that you should use anticoagulation necessarily prophylactically, but if thromboembolic events have occurred in the patient in the past, let's say they've had a stroke, or they've had the Budd-Chiari thrombosis, or they've had these dermal these dermal nodules, then you should use antithrombotics. So you can use, generally you use like heparin. And if the patient is pregnant, again, you should use heparin. Don't use Coumadin in a pregnant patient. Heparin, heparin, heparin. Okay. But no for the USMLE, iron and folate supplementation. Okay. G6PD deficiency. So this is a common one. This is really, really common. And you'll see this a lot in the patients that have a tendency towards malaria. So this is an X-linked recessive condition, so it's going to be most often on the USMLE. It's going to present in boys. Most often in real life, it's going to be in boys. And I say boys because often it presents during childhood. So this is a deficiency of a specific enzyme, and that enzyme is glucose-6-phosphate dehydrogenase. And that is an enzyme that's responsible for various things with sugar, but what's important here is that it actually, if you have a decrease in that enzyme or an absence of that enzyme, you're going to have a reduction of the byproduct that's actually responsible for oxidating or dehydrogenating the glucose-6-phosphate, and that is NADPH. So you'll have a deficiency of NADPH, and that can actually be a problem because NADPH, with that hydrogen ion on it, is a very potent antioxidant. So if you don't have that antioxidant, the red blood cells are going to be very, very, very susceptible to oxidative stress. As I mentioned, this is going to be most prevalent in patients that are possibly evolutionarily exposed to malaria, so blacks, Asians, and Middle Easterners, and Mediterraneans as well. So a lot of times this is going to present in pediatrics and children, and this is going to be acute. It's going to be a sudden hemolytic anemia. So it can be linked to infection, and most often is in conjunction with an infection. It can be linked to oxidative drugs, sulfas, dapsone, nitrofurantoin, all of which coincidentally are antibiotics. So maybe you don't know if it's linked to the drug or the infection, but it doesn't matter. Your treatment's going to be the same. And it can be linked to certain foods. The most common one is fava beans. That tends to only present with the Mediterranean population. So that's kind of a little morsel of knowledge to know. The symptoms of G6PD deficiency are acute hemolytic anemia, jaundice, and splenomegaly are going to be prominent in acute attacks of G6PD deficiency. For diagnosis, oftentimes there's going to be a family history, but it's usually going to be pretty easy to diagnose this. And apart from the fact that you're going to have your classic lab values of hemolytic anemia, your low hemoglobin, your low haptoglobin, your high LDH, your indirect bilirubin, you're going to also have suspicious things showing up on your peripheral smear. So you can have what are called Heinz bodies, and Heinz bodies are just little purple spots in the red blood cells. And all that is oxidized, denatured hemoglobin. And then you can get bite cells as well. And bite cells are red blood cells where they've gone through the spleen, and the spleen has said, oh, look at that ugly Heinz body. I'm going to take that out of the red blood cell, and it munches it right out. So literally a bite cell. If you were to do a Coombs test, it would be negative. And a lot of times, clinicians may do a Coombs test to differentiate this from drug-induced hemolytic anemia, because sulfa drugs can cause drug-induced hemolytic anemia. They can also cause G6PD deficiency. So there may be that confusion there. But G6PD deficiency, you're going to have a family history. And you may have a repeated history without exposure to that drug. The treatment is going to be to stop the offending drug or the food, or to treat the infection, preferably with not one of these oxidative drugs, of course. And hydration can be indicated in cases of severe hemolysis. Of course, you're going to want to educate the patient, make sure that they're aware of their G6PD deficiency, and especially if they're Mediterranean, aware of foods that they shouldn't be eating. So the smear in G6PD deficiency, this is a smear in a patient with G6PD deficiency. And you can see the Heinz bodies. They're kind of small, but here's one. Here's another one. Here's a third one. So these are just aggregates of hemoglobin, and they stain purple on your typical stain. And then bite cells, let's see, here's what looks like a bite cell right here. So you could have had a Heinz body sitting right here on the periphery, which is where they tend to sit, and the spleen just chomped out part of the red blood cell. Here's another one here, and here's another one here. These look kind of denatured, but that's Heinz bodies and bite cells, and they come up with G6PD deficiency. And right there, immediately, when you have that on your report of your smear, that right there is going to tell you this is G6PD deficiency. And that's it.